Hello, everybody, and welcome to this edition of MacroPro and Friends. I'm Diane Cohen, and I'm Vice President Client Services, and I head up the Educational Department for MacroPro. We are a document retrieval company. We can get records for your litigated and your claims files. So if you need anything, be sure to call on MacroPro. Today, I'm joined by Graciela Ojeda, one of my colleagues. Graciela, how are you today?
I'm doing fabulous, Diane. How are you?
I'm doing great. Thank you. I understand that today you have a friend that brought to us our guest speaker.
Yes, I sure do. But before I introduce Veronica from iLingo, good morning, Veronica. We do have a couple housekeeping items that we need to go over. The handouts are attached to this presentation, so please download them now. And if you have any questions, please use the chat box and we will do our best to have our guest expert answer them for you.
In addition to that, we're all here for our CEU credits, so we want to make sure you know that you'll be receiving those by the end of today in your email. So make sure you start looking for that. Now, it's very important that you know that you must be logged onto the system in order for GoToWebinar to be able to account your attendance and the amount of time that you've been online with us. So if you're just calling in, make sure that you also log on, because otherwise there's no record of your attendance, and we want to make sure that you get those certificates. All right, so Graciela, tell us a little bit about Veronica.
Well, good morning, Veronica. Welcome.
Morning.
So everyone, this is my friend Veronica with iLingo. Good morning, Veronica.
Good morning, everybody. Thanks for joining us today. I'm with iLingo. We are a transportation translation company. So if you need any assistance with our services, reach out to me. Today, I would like to introduce Dr. David Lee, who is certified in pain management. And Dr. Lee, thank you so much for joining us today. And I'm going to turn it over to you for your presentation.
Great. Thank you, guys. So I want to first thank everybody for joining us here. I'm going to kind of relatively keep this brief in terms of introduction, so we can get kind of into the meat of the discussion here. And if, as they said, you guys have any questions or concerns, please feel free to reach out here. So today, specifically, I wanted to cover a treatment algorithm for low back pain and sciatica for a multitude of reasons here. Before I go into that, just a little bit more about me personally. So I'm actually double board certified in physical medicine rehabilitation, as well as in pain medicine. For those who aren't familiar with PM&R as a field, it is kind of a mixture between musculoskeletal medicine and neurological medicine. So when a patient comes to see me, we literally are able to evaluate the patient physically. We do neurological examinations, both in office as well as through EMG nerve conduction studies here. And then one step further, with my fellowship training, I'm able to then treat those pain symptoms, both with pharmacological management as well as various interventional procedures, which we're going to discuss here briefly. Presently, I'm the only non-surgical specialist that works out of Fullerton Orthopedic Surgery. So just some quick disclosures. I trained in all over the place, you'll see here, and I'm kind of keep myself busy outside of the office with a multitude of different societies and organizations that I'm actively a part of, and I'm chairing multiple different committees, all of which are within the field of physical medicine, rehab, and pain management. So today's lecture, we're going to be looking at both the anatomy, biomechanics of the lumbar spine, and how sciatica occurs. We're going to discuss various conservative treatments for sciatic symptoms, some of which you guys may already know, but we're going to kind of reinforce those things, understanding what types of injection procedures, surgical procedures may be required for patients who don't respond to conservative management, as well as an overview of return to duty timeline and strategies that I kind of implement, not only in the work comp field or the personal injury field, but also just generally, in all patient population. So, the way that I often talk about the lumbar spine to my patients is I like to try to keep it simple. And I'm going to do the same thing here. So if this seems a little elementary or redundant for many of you, I do apologize. If you have Q&As afterwards, we can go over a little bit more detailed anatomy at that point in time, but I'm going to keep it relatively straightforward here. So when I describe the lumbar spine, in particular when I'm looking at x-rays or reviewing a CT scan or MRI with a patient, I often equivocate it to something that they can identify. And one of the things, I don't know why, but I always use food. It's close to lunchtime, so maybe that's appropriate. So if you look at the spine, and this one is turned on its side, of course, because if I turned it right side up, it would be a tiny picture. So I made it kind of go lengthwise here. But I think of it like a box of Oreo cookies when you first open them, or Girl Scout cookies, if you can imagine that. You can see the diagram on the right lower corner of the slide. And what you have essentially is you have cookie, frosting, cookie, frosting, cookie, frosting. And people get very intimidated when they think of the spine in terms of its anatomy and its mechanics. But again, it's relatively and elegantly simple. So if you look at the spine, you'll see there's bones, and the bones are shown on this particular slide, kind of in the tan, kind of the taupe-like colors. And then the discs are the gray objects that are much thinner that kind of interdigitate between those bones. So if you think about it in that way, you have bones, which are the cookie, and then the frosting, which are the discs. And they function in the same way. The bone gives us structure. It allows us to stand. It gives us posture. It gives us form. And then the disc is kind of malleable. It's flexible, so you can bend and push and pull on it, and kind of distend and give, and just like a pillow would. And that's what gives us our range of motion. So there are four obviously parts of the spine. We're going to be focusing primarily on the lumbar spine here today because it is where most injuries occur, and they're designated by these different colors. And you can see that the segments change shape as you go from cervical, which is closer to the neck, thoracic, mid-back, and lumbar, lower back, and then of course the sacrum, which is the tailbone. So just a little bit additional anatomy of the lumbar spine. When we get more into kind of the nuances of the spine, one of the reasons I put this picture up here is not to overwhelm you as an audience as to what's going on, but I did want to point out a few other things. So in addition to structurally, allowing us to bend, move in different ways, the lumbar spine is also important because it protects the nerves in our body. So we have in the canal here, and you can see on the image here that it's showing the cauda equina. Cauda equina is the nerves that traverse the lumbar spine. And cauda equina in Latin is horse's tail. So that's literally what it kind of looks like. So whenever I'm showing a patient an image, I'm saying it looks like kind of like a ponytail or a horse's tail there. Well, those are the nerves that are kind of dangling in the lower portion of your spine. And so there's a canal there that's protected by the bone which surrounds it. The disc that gives us that range of motion sits right in the front here. I know I don't want to confuse things here, but I'm going to use kind of my arrow here just to show you that the disc is right here in the front here. So this is the top-down view, and this over here on the left side is the side view. So here is where the nerves are, kind of sitting right behind the disc, and then you have all this kind of brown or taupe-like bone that surrounds it and protects the posterior aspect of the spinal nerves and the spinal cord. Why is that important? Well, there's a mechanical aspect to this which causes sciatica. So what you're seeing on the top right corner is showing kind of different movements that occur when you bend forward. So as you bend forward, which is shown by this dark black arrow that is demarcated with the letter F, then what happens is that the disc gets pressurized and it forces pressure on the disc backwards towards where the nerves are. And normally you have outer annulus of the disc which protects it so it doesn't bulge out too much. But with repetitive trauma, or which can occur over time, or if you're involved with a significant accident which then tears the backside of the disc can get close to the nerves, and then that's when typically people get sciatic symptoms. The diagram that's shown on the screen that I've set before you was actually taken directly from a historical study. And what they actually did was, it sounds kind of strange to say it now because it probably will be less PC to do, but they actually took a manometer or a pressure gauge and they placed it in cadavers and they put them in all these different positions. And the reason they did that was they wanted to see what positions cause the most pressure in the lower lumbar discs, which typically get injured most statistically in our society. And so you can see here, lying is pretty low on that list. You can see that about 25, 75 relative number compared to when you bend forward, whether you're standing or you're sitting, it goes up to upwards of 200 plus. So when part of what we do when we're engaging with patients and talking to them about their disc herniation and their sciatic symptoms is also educating them on things that would exacerbate their symptoms or is going to make their symptoms worse. So to get into what exactly is sciatica, and sciatica is a terminology that's kind of thrown around loosely here, but for a most kind of a rudimentary understanding of what it is, essentially it is any kind of leg pain symptom that is originating from the spine. The sciatic nerve is actually, people always refer to it as one specific nerve, but actually it's made up of several different nerves that exit the lower back, and then they come together like you're seeing in the picture there, and they radiate typically then down the leg and potentially all the way down to the foot. And usually there are a couple of reasons why you can have sciatica, but the most common is a herniated disc. So in this kind of subset picture on the most right-hand side, what you're seeing is actually the disc kind of pushing out there and then touching up against the yellow nerves. And essentially then what sciatic is your body's way of telling you that something is getting close to that nerve and it's becoming inflamed and irritated. So because the sciatic nerve is made up of a bunch of different nerves, sciatica can present in different ways. Classically, when we think of it, and laymen think of it as sciatica, it's usually that more classic posterior buttock thigh down to the foot type of pain. But what you can see here, and I've included this particular diagram, is depending on what nerve is actually being pinched specifically, you can get different types of distribution. We call these dermatomal maps, and there are these huge diagrams where they show you on a human or even animals where each different nerve root travels in terms of the sensory coverage. So you can see here at L4, it usually kind of wraps around the hip, and then it goes down the anterior thigh, typically then travels down the shin and sometimes down to the middle ankle. L5 is usually the posterior lateral thigh, calf, and then the side of the foot. And then S1 is that typical sciatic symptom that we often equivocate, which is more buttock, thigh, posterior calf, and then bottom of the foot. And the other thing is that they also control different motor aspects to our legs. So the quads are L4, dorsiflexion of the foot, or bringing the foot, upwards towards you. If you're bringing your ankle towards your body, is L5, and then S1 is kind of that push-off maneuver, bringing your ankle in the opposite direction or kind of going on your toes. That's S1. So this is a kind of a general diagram that I've seen often kind of circulated for patients to kind of get a general idea of what sciatica is. I like the diagram here. I'm going to go over it just very briefly. I like it because it's very digestible. So just some interesting facts about the sciatic nerve. So this is one of the longest, widest nerves in the body, and obviously that's pretty obvious because it goes all the way from our back down to our toe. Sciatica, as we discussed, is commonly a result of a herniated disc, but it can also be a result of other things as well. So bone spurs, narrowing of the spine further up, not just in the lumbar spine. Pregnancy can put pressure on the sciatic nerve, as well as changes in one's body habitus, so weight gain and things of that nature. Common occupational triggers, so prolonged sitting, prolonged standing, twisting, believe it or not, again, inactivity, which is not something that we typically think of when we're thinking of injuries. Lifting, carrying heavy objects is a more obvious one. Common sciatic symptoms, low back pain. This includes also then radiating pain down the leg. Numbness and tingling are the most common. In severe cases of sciatica, you can sometimes get also bowel and bladder issues. But however, when those symptoms are present, it usually indicates more of a surgical emergency. And so those symptoms we take a little bit more seriously and generally start to be a little more aggressive in terms of treating those. Sciatic symptoms usually involve only one side, and that's quite simple. It's just anatomical. When your spinal cord descends your back, think about it like a tree. So you have branches that come off the side, and obviously on the left side, it innervates the left side of your body, and then on the right side, the right side. So the same thing in your lower back. The left nerves, L1 through L5 and S1, they all go down the left leg, and then the ones on the right go down the right leg. Staying active and eating healthy obviously can help reduce sciatic symptoms. And that's due to a lot of things, mechanical issues as well as reduction of weight, so there's less stress on your back, and also good core strength is helpful. So I wanted to include an MRI because I know, again, people similarly for approaching the spine, they get fairly intimidated when looking at an MRI, but for everybody on the call, after hopefully this discussion, you'll have at least a better appreciation of what an MRI looks like, and so you can actually look at one and feel a little bit more confident. So I'm going to use my arrow here again. I don't want to do that too much here. It's just I don't want to be all over the place. But this is a side view. So this is as if this here, back here, is the person's skin. The black here is the table. You'll see these kind of teardrop-shaped objects back here, and those are what's called the spinous process, and that's the bone in the middle of your back. So we're kind of cutting directly down the center of this particular individual. As we pointed out in the previous slides, you can actually see the spinal cord here and the cauda equina, which is, again, looks like a horse's tail. The white here is the spinal fluid that's protecting the spine and the nerves. Without that, the nerves would just be dangling in the canal by themselves and would be damaged with any type of movement that we make. So it's invariably important. This spinal fluid is also what they get to sometimes if they're trying to do a spinal tap. Up here is the structural part of your spine. So you have, again, just like that Oreo cookie that we alluded to, you have bones here, and then in between those bones are all the discs. And we name the disc based upon the bones they fall between. So if you look up here, you have the L1 vertebral body. There are 5 lumbar vertebral bodies. Here is the L2. So the disc that falls between that is then the L1-2 disc. People get a lot of, obviously very confused because nobody describes that to them. So there's a lot of alphanumeric codes that are kind of in jargon that are typically thrown around on these MRI and CT scans. But if you remember that the disc is simply named after the bones that it falls between, then it makes it relatively simple. So on the left-hand side of the slide, you'll see a completely normal MRI. On the right side, not so much, right? Now, as you can kind of see down here, the very lowest portion of the right-sided diagram where my arrow is here. Oops, sorry about that. You'll see that there is an actual disc herniation. So that you can see that the frosting has squished down, and as a result of that, it's now pushing posteriorly towards the nerves, and that you can see that white arrow is showing the actual disc herniation. So this is just showing side by side of the anatomy again from the top-down view, which is a little bit different than the image that we were just looking at. But similarly, again, you can see the same concept. So the disc is the blue object at the very bottom. When it herniates backwards and touches up against the purple nerve, that's when sciatica typically occurs. So one thing that I always emphasize to all patients, providers and lectures that I do is treatment of spinal issues are not always simply surgical versus non-surgical. I know that's kind of always the first question that most people have, but rather there's a treatment algorithm, and it's a comprehensive one that includes both surgical and non-surgical options. So treatment algorithm generally starts from less invasive, which is the top, and then as we go down on this list here, it gets a little bit more invasive. So physical therapy, chiropractic, acupuncture is usually the initial trial for any patient who comes to my office. If they haven't done any of that, then it's one of the things that we do almost immediately. Again, the only times that this may be an exception is if the pain symptoms are just extraordinary, where the patient is completely debilitated, they can't perform physical therapy, they can't tolerate chiropractic manipulations or acupuncture, or they have progressive neurological symptoms. In those cases, we do move a little bit with more haste, and we treat the patients more aggressively. In addition to physical therapy, medication management is important, and even though I'm board certified in pain medicine, I do try to take advantage of non-opiate, non-controlled substances. So there's, as a group of medications, really quickly, there's non-steroidal anti-inflammatories, there's muscle relaxers, there's nerve medications like gabapentin, Lyrica, Cymbalta, which many of you have come across just in your reading or even personally. And then, of course, the opioids, which we want to try to limit in terms of the use by the patient. Further workup and imaging is then usually necessary if they fail those conservative managements, and then interventional procedures, which is where I kind of fit into the picture. And if they still don't do well, then usually I'm having a different conversation with them, like, look, we've tried A through Y, and surgery is certainly the last resort, but sometimes that's the case. So I wanted to go over the most common treatment, interventional-wise or procedural-wise, that we do for sciatica, and that's the epidural injection. So everybody has heard of what an epidural is, but few have seen the actual picture and how it's done. So I'm going to kind of show you on the diagram here. There's two separate ways to do an epidural injection. There is an interlaminar approach and there's a transforaminal approach. There's different reasons that I do that. So the interlaminar approach is the approach that most people are familiar with. If you've been pregnant or gone for delivery and you had an epidural injection, the epidural at that time was delivered via the interlaminar space. The interlaminar space is, and this is an X-ray of looking from front to back. So the middle of your spine is here. This is the spinous process, the bone that protrudes out. And then there's actually, you can see, and it looks like lips here, if you look very carefully. One time a colleague of mine was very poignant, and he said, it looks like Angelina Jolie's lips. And these ones are pretty, this is a very large interlaminar space, so I'd say that that's a pretty accurate description. And he said when you're doing an interlaminar injection on the X-ray, you want it to look like Angelina Jolie is sipping from a straw. And so if you look at, this is the needle, this is actually going down, so we're looking at it from the top down. So this is the hub of the needle, and this is the tip of the needle. You can actually see it going directly into this white radiolucent space. On the right side of that picture, you're seeing kind of a more gross demonstration of how that would look. So you're going, the yellow elements of the nerves, so we're going between the white bones there into the interlaminar space. Another option that's been more recent over probably the past couple decades is the transforaminal approach. So now we're looking at the X-ray from the side, and if you turn your attention down here, you can actually physically see the hole where each individual branch comes out. So this is a little bit different of an approach. What are the advantages and disadvantages? Very quickly, transforaminal approach, because we're specifically targeting one or two nerves, it's more accurate versus if you're doing an interlaminar approach that we previously discussed, the medication is going to spread widely. If the patient has a very specific pain pattern, like it goes like a strip right down their leg, like very characteristically L4 or L5, like in my previous slides that I pointed out, I'll do a transforaminal approach. If the patient has more diffuse symptoms, like Dr. Lee, my whole leg hurts, or multiple parts of my leg are kind of tingling or numb, then I'll usually elect to do an interlaminar approach because it's going to allow for more wider coverage. This is showing the transforaminal approach in more detail. One of the reasons I included this is to show that we use multiple different fluoroscopic or X-ray images to confirm appropriate needle placement. What you'll see here is A is pointing to the needle actually coming into the hole where the nerve is. B is showing you and B and C are both showing you the contrast as it's spreading into the epidural space. So if you inject contrast and it's just kind of a blob, that means you're not actually in the right location, in which case you need to relocate the needle appropriately. So one of my last slides here, post-operative course and return to work. So general response to epidural injections is most optimal when intervention is provided in the acute and subacute stages. And what that means, as most of you understand, is within the first few months. So when I see a patient, generally speaking, that has sciatic symptoms, I immediately get them into the treatment algorithm, right? So if they haven't already, again, physical therapy, chiropractic, or acupuncture. If they've done maybe some of that but not consistently, then I re-emphasize that. getting them on some kind of anti-inflammatory muscle relaxer combination can be helpful to make sure that they tolerate as much exercise and physical therapy or treatment as they can. If they don't do well, we start to advance them through that algorithm relatively quickly, because we know the earlier we can catch these patients, the better their outcomes generally are. If you look at any other study, you'll find that across the board. Return to work and success outcomes decline sharply thereafter. So if you look at most studies, anything after 6 months, which unfortunately is the case with some of these patients who have cases that have been going on for quite some time, where they have pre-existing injuries or chronic pain in addition to whatever they're dealing with now. There is statistically a less likely chance that they're going to make a return to work as successfully as the others. Epidural injections and use of analgesics may reduce the time and expedite the return to work times. I just mentioned that. Injections, epidurals specifically, allow avoidance of more invasive treatment options such as discectomy or fusion surgeries. Discectomy is where they remove part of the disc to take pressure off the nerve or decompress the nerve. You may have seen that terminology thrown around. And fusion is where they actually put metal screws or hardware to ensure that you no longer can bend through the area where the disc herniation has occurred. Generally speaking, my approach is patients may resume activities and therapy shortly after their epidural. Historically, people have thought, well, I have to lie down for 24 hours, I can't do anything, and that's absolutely kind of an antiquated approach. You can actually move around just fine. The medication doesn't spread or doesn't move as a result of that. It doesn't work that way. It usually stays right where you inject it, maybe moves, maybe hypothetically up 1 or 2 levels, that's it. And then I reevaluate patients generally in 1 to 2 weeks, and that is purely pharmacological, meaning that the steroid stays into that area for about 2 weeks. It doesn't stay there forever. Another misconception is that the steroid medication stays there for 6 months and then you need to have a new injection again, and that's absolutely not true. Steroids don't stay in your system that long. No medication does. Most medications are broken down or metabolized within 1 to 2 weeks, and then the medication is gone. So by that 2-week mark, it's a great time to reevaluate the patient, because if they're doing great, all that you can tell them, medication's out of your system, it's done what it needs to do, the inflammation is gone, the nerve is has kind of repaired itself, and you can start to gradually work yourself back to your normal daily activities. In some instances where patients maybe get partial relief or are not 100% back to their normal baseline, kind of work restrictions and light duty may be necessary, but I kind of limit that to the first few weeks. This last slide just shows you different interventional spine procedures that I also do in addition to epidurals. I think one of the last misconceptions that I'll kind of discuss is that I just allude to is that some people think that I just do epidural injections. That couldn't be further from the truth. I do probably about 10 different types of spinal procedures and non-surgical spinal procedures. Epidurals, facet injection blocks, radiofrequency ablations are by far the most common, but it goes into sacroiliac joint injections, selective nerve blocks, peripheral nerve blocks in the arm, hands, ankles, knees, sympathetic nerve blocks for diagnoses like complex regional pain syndrome, and then kyphoplasty, vertebroplasty for compression fractures, and then even neuromodulation in certain instances. So this is just a little information here. If you guys feel free to, you guys have any questions or interested in kind of what we do over here, you can please feel free to reach out anytime. We have our workers' comp website, of course. We have our Fullerton Orthopedic website as well that has additional information. And then I also have my personal website listed there, which also includes a little bit more information regarding the procedures we just discussed. Thank you.
Leslie, do you have questions for Doctor?
I do have questions for Doctor. Doctor, one of the questions is can you explain the kyphoplasty and the vertebroplasty, what that is?
Yeah, absolutely, sure. I'd love to. So, so first, when we do a kyphoplasty, the main reason that we do that for the diagnosis is that a person has a compression fracture. And so actually, if you guys don't mind, real quickly, I'm going to take this model back here off here. I figured that this might come in. So, so if you remember the the anatomical discussion that we just had on the slide, the kind of cookie is here, right? This one actually has a herniated disc next to it, so ignore that for a second. But this is the cookie here. This is the vertebral body. This is the meat of the bone of the spine. And in patients who have osteoporosis or some kind of trauma, this actually can fracture down. So think about if you exert a large amount of pressure here, just like the disc, it can squish down. Using the analogy of the Oreo cookie, it's like if you took that Oreo cookie and squeezed as hard as you possibly could, that cookie eventually will reach the point where it's going to start to break or crumble. So the same thing is to be said about this vertebral body. When we do a kyphoplasty, what we're actually doing is from behind is I actually insert a needle. It's a diamond tip needle that goes actually into the front of this bone. And I basically create a little channel or a little tube that then you introduce cement. And as soon as that cement then hits body temperature, it hardens almost instantaneously. We wait generally about 10 to 15 minutes. The patient's going to be lying supine or lying face up. But once that cement hits the bone here and solidifies, that fracture is almost instantaneously then stabilized. So no longer does the patient have pain. So if you have a patient who has an acute compression fracture, and they're on the particularly their older side, or they're having, even if they're on the younger side, they have severe amount of pain. That's a potential option for them that has really good outcomes. It works almost instantaneously. Somebody asked me the other day, I was having dinner with a colleague, and they're like, "What's your most favorite procedure?" I like doing all the interventionals, of course, but particularly I like kyphoplasty because it's immediate gratification. You do a kyphoplasty for a compression fracture, the patient lies there for about 10 minutes, then gets up, and they almost immediately then notice that they have minimal back pain because now the fracture is no longer an issue. Great question.
Thanks, Dr. Lee. Can you also, we have a question here asking if you would talk about radiofrequency and ablation.
Yeah, so as I alluded kind of that last slide, radiofrequency is probably one of the more common procedures that I do. So I think a common misconception, I just had this discussion with a patient this morning, is that people always ask, well, I have sciatica, can't you just burn that nerve and get rid of it, get rid of that pain down my leg and in my back? But the thing is, so radiofrequency is a completely a different indication. So when we think of radiofrequency, if you were to burn this nerve, this dorsal root ganglion, this nerve here that comes down from your back and goes into your leg, you would have a lot of problems, because if you burn that nerve, you're going to have probably increased pain, and you're also going to have issues with motor function because you've now compromised the function of that nerve. You basically have killed that wiring. When we talk about radiofrequency ablation, we're talking about patients that specifically only have axial back pain, so no sciatic symptoms whatsoever. And we have to identify the pain coming from a very specific area, which are called the facet joints or facet joints. So we didn't discuss this is like a whole nother separate lecture it could be, but I'm going to kind of show you briefly because it's a great question. But back here, what stabilizes the spine is you have these little joints here. I'm sticking my finger, it's kind of hard to see, but I'm kind of sticking my finger directly into the joint there, and you can see there's a space or gap here. It's very close to that nerve over here, but it's back here. It's in the back of the spine. And what I'm showing you right now is the spine as if you're looking, from back to front. So this is the bone in the middle of your back, just a little bit left and a little bit right. There are joints that support your spine. So how do they support your spine? Well, if I rotate the spine, you can see that joint makes it so that there's a stop, right? And if I extend the spine, the same thing. If these joints weren't back here and you were turning like around or rotating and looking behind you, like if you're backing up your car or somebody calls you from behind, your body would just continue to turn. It's just like, it would be like one of those horror movies, right? So these facet joints are very important in stabilizing the back of the spine. Unfortunately, they are not impervious to damage. So you can get arthritis back here, right? You can get degeneration, you can get inflammation in the joints, just like your knee, your hip, your shoulder. So how do you treat that? Well, you can inject steroid into the joint, but sometimes that only provides temporary relief. The other thing you can do is you can actually denervate the joint or take away the nerve supply. And that's where radiofrequency ablation or neurotomy comes about. So we put a needle back there. The needle is attached to a radiofrequency machine, which then heats up the tip of the needle, and it literally cauterizes the area around that joint. So the patient can no longer feel the pain that's coming from that area. Hopefully that wasn't overly complicated.
Thank you, Dr. Lee. Another question is, what is spinal cord stimulation? What is it treated for? Who is a candidate? And are there any new devices?
Yeah, so that's a really loaded question. There are about over 10 new companies of neuromodulation now in the last in the last probably decade that have come about. Even the older companies that are out there like Abbott, Medtronic, their products are completely different than they were a decade ago. Again, this is a different lecture that I give completely because I do a lot of neuromodulation. It's like kind of one of the things that I particularly fond of. We use the most is kind of a not a last resort, but a later resort in terms of patients who have failed, their traditional epidural injections, facet injections, radiofrequency. So anybody who has chronic, neck pain, back pain symptoms, one of the most classic patient population that we treat with spinal cord stimulation is patients who have what's called failed back surgery syndrome. I hate that terminology because it implies that the patient has done something bad or they're kind of like a hopeless case. But patients who have had some kind of surgery, a laminectomy or a fusion, but they still have chronic pain, and this may often accompany the use of higher dose opiates or chronic use of opioids. So what we do is we actually put a lead, it looks like a spaghetti noodle, into the spinal canal. So that interlaminar space that I was showing you on the epidural, for those who remember that slide, instead of putting cortisone in there, we just put this little noodle lead into the canal. And what that then does is it's attached to a generator and it emits like an impulse or signal. And there's a lot of science and a lot of nuance that's involved there. Mechanism of action is always a kind of a discussion topic when it comes to a lot of meetings I go to. But on a very rudimentary, basic level of understanding, it interrupts the pain signal that's coming from your arm, your back, your leg, that then travels up to the brain. So if you think about it, if you have this constant signal telling the brain that there's pain coming from the leg, despite having had epidurals, physical therapy, medications, surgery, and nothing is helping it, then you can actually modulate that signal or block that signal. Then the patient can actually obtain pain relief. The beauty of the spinal cord stimulator is that and the reason I was kind of drawn to it initially is one, it treats sometimes the worst of patients who have been through everything, right? And historically, when it came to pain management, it was basically at that time, my predecessors would say, well, we tried everything. You're going to be on OxyContin for the rest of your life, or you just deal with it, right? And then patients would be kind of left to their own, unfortunately, to their, independent on their own, trying to struggle with this on a day-to-day basis. So one reason I was drawn to it is that it helps the people who absolutely are in the worst of situations. The other thing too is that it does help in terms of keeping patients away from the opioids themselves. And as you guys know, in this climate where opioids are becoming less and less available, that becomes has come to the forefront of what alternative options do we have for these particular patients. So what I was going to say was that there's a trial. So we don't just implant these things like you would like a pacemaker. You do a trial first, and based upon the success of that trial, then you decide whether an implantation is to be done. And usually the cutoff is about 50%.
Great, thank you so much, Dr. Lee. One more question. Someone had asked, what about arthritis in the spine or around the spine that also compresses the canal area?
So arthritis of the spine can, if it's starting to encroach on the neural elements and the actual spinal canal itself, can be a problem. The nerves are very resilient in the sense that if you as things kind of get tighter in the canal here, so again on our model here, oftentimes arthritis will either go in towards the spinal cord or out towards these foramen here, these little individual branches. So, but the nerve is very smart, so it will accommodate to a tighter space to a certain point. So, when you look at sometimes these MRIs and X-rays, I'll see people who are very tight, in their foramen or in their central canal, and I would anticipate that they would have a lot of leg symptoms, and they don't. So it just shows you how resilient those nerves can be. But there is a point in time where tight is just too tight. I often explain it to a person who's ever lived in a high-rise building, or you're in a hotel and you're going up the elevator, and you're the first person in the elevator and everything's fine, but you're on the top floor, and so people keep piling in, over, and it just keeps or if you've ever lived in New York, which I did for a few years, it's just like being in a subway at rush hour, and people just keep piling in. In the beginning, you're like, okay, this is okay, I can deal with this. I'm pretty patient. But there is eventually going to be a time where you just hit your tipping point. You're like, I can't take this anymore. This is too much. And the same thing happens to the nerve. When that occurs, we do try epidural injections first. It doesn't change the bone spur being there. So I always kind of preemptively tell patients, like, look, we're going to try to calm this nerve back down again, but it's not going to get rid of the bone spurs that have grown there. And sometimes you'd be surprised, in a lot of cases, more than 50%, their pain symptoms go away. The nerve calms back down, the bone spur is still there, but it's not irritating things any longer. So they go back to their normal daily activities. And I just caution the patient, like, look, if the pain symptoms come back again, we may need to do another injection. But if those injections aren't helping, then you may need to go have that area basically cleaned out. And so that would be the surgical treatment for that, is that sometimes they can go and do what's called a foraminotomy, where they go and scrape the area where the foramen, or the hole where the nerve is located. And sometimes they can do what's called a laminotomy or laminectomy, where they remove the back portion of the bone. So those are more surgical procedures when patients have failed the algorithm that we discussed.
Doctor, I see there's another question. There seems to be quite a few, so we have time. I'd like to ask this one of you. It says,
Absolutely.
how important is the removal of screws for a fully healed spinal infusion?
It's not. So it's a question I get often asked. So when they put screws, during a fusion, the intention is to brace the area, right? You don't want to bend through these segments, right? So you put these metal rods in it to hold it together. But the hope is that one's body creates a natural fusion, where bone starts to grow around those metal rods and screws. Usually after that's happened, the surgeons will just elect to leave the hardware there. Unless it's causing some kind of problem. And in very, very rare instances, hardware can sometimes be painful. That's the exception, not the rule. Then sometimes they'll elect to remove it. But oftentimes they just leave the hardware in place, and the patient lives their normal life.
Well, speaking of pain, someone's asking, is a pain pump recommended for patients that have had failed surgeries and injections?
Yeah, that's a great question. So you'll notice, and somebody got me, but that I didn't include pain pump in that last list on that last slide, because I actually don't do pain pumps. I mean, it's not because I can't. I've done them. I've managed them. It's more of a philosophical thing, as well as a resource thing. So when you have a pain pump practice, it does require a lot of attention. You get phone calls day and night with people who have failures of their pain pumps or complications from their pumps, and that's one of the things that I caution people when they're considering doing pain pumps, is that there are some risk involved there. You can develop scar tissue or granulomas in the spine. You can have infection, that spreads to the spine as a result of the pain pump catheter being there. what I have noticed is that with the improvement of a lot of other pain treatments, like specifically spinal cord stimulation, I've noticed the number of pain pumps being implanted drop significantly. Why? I think a lot of patients like the idea of would rather opt for putting a stimulator which involves no medication versus a pain pump that goes into your spine that's still delivering potentially narcotics or opioids directly to your spinal canal. So when I propose things, I do tell patients, look, a pain pump in a chronic situation is an option. So to answer the original question, yes, it is an option, but I often will try to elect to do it the non-pharmacological way. So if I can get people away from opioids or away from more medication being pumped through their system, for me philosophically that makes more sense. But it is an option. There are people who do pain pumps still.
Leslie, do you see some more questions?
There was a question on here, Dr. Lee, in regards to utilization review non-certifying epidurals because MTUS does not recommend it. You have any comments on that? I'm sure you and I have lots of comments on that, but what can you tell us?
Yeah, it's funny because, like, if you look at ACOM and MTUS, and sometimes they're a little bit conflicting in terms of what they suggest and whatnot. I mean, I obviously disagree with that. I mean, there is a profound amount of literature to support the use of epidural injections for radicular symptoms, So I think it also depends on what diagnoses you're specifically talking about, because if you're just talking about back pain is obviously a lot of times alone, but without sciatica, is not recommended. Epidural injection is not recommended for the treatment of just axial back pain. But for sciatic or lumbar radicular pain or cervical radicular pain, it absolutely is. And there's a profound amount of literature that's out there that to support that, and there's constantly reviews and systemic reviews that are kind of again re-emphasizing that that's the case. The other thing too is and I often I've done obviously a lot of peer-to-peers in my day, talking with doctors both in work, now PPO insurance is happening more frequently, but historically with workers' comp, is that I always ask the provider who's doing the review then, like, what do you suggest is the alternative then? So that's maybe less of a scientific approach, but it is a valid question, because if you have a person who has a radicular issue, which we know from the literature that can be treated with an epidural injection, not all of them are going to be successful. That's if anybody says anything is 100% successful or even like 99% successful, then you should have skepticism immediately and run the opposite direction. But for majority of patients, they respond really well. Again, more acute, better outcome. Chronic, lesser outcome, and that's sometimes where also MTUS gets kind of hung up on. But still, the alternatives for even chronic radiculopathy or sciatica is surgery. So, or narcotics, long-term narcotics. So, when I propose these things, I always kind of make a case like, okay, well, one, the literature supports it. If you look at the literature, even outside of MTUS, it supports it. Two, if the indications are appropriate, the alternatives are massively more aggressive or less enticing, right? So you're talking about surgery or long-term narcotic medication management.
All right.
Hope that helps.
Leslie, are there any other questions for Doctor?
I think one last quick question that you can probably answer, Dr. Lee, is someone asked, how long are the benefits for a patient that has kyphoplasty or vertebroplasty?
Benefits from a kyphoplasty are forever. Once that stabilization of that compression fracture is done, then pain is gone forever. That is unless they fracture either the same bone or a different bone. That is a concern with persons who are osteoporosis, have osteoporosis, who have very thin bone to begin with, who tend to be the majority of people who develop these compression fractures. You do have to monitor them, and if they do come in with increased back pain all of a sudden, then the question is did they establish a new fracture? How do you know? You get an X-ray, compare it to the old one. If it's still inconclusive, then I usually get an MRI. And if the MRI lights up like Christmas, usually that bone will be full of fluid. It'll light up like a Christmas light. Then you know that something bad has happened there. In which case you may have to be having discussion that kyphoplasty needs to be performed again. Usually at the same level is a little difficult, but if it's at adjacent level, then it's kind of a no-brainer. One question about that, which actually I'll discuss, because a lot of people ask how long do epidurals work. I didn't actually discuss that in my lecture. And again, there is a kind of a misconception that epidural injections need to be repeated on a requisite basis every 6 months, and that's absolutely not true. You know, one of the things that I kind of have made it a goal in my life is to kind of demystify what epidural injections are. So again, by 2 weeks, all the medication is out of the patient's system, and whatever relief they get is, fingers crossed, permanent. But if the patient doesn't change their habits and doesn't do anything to better their back, your strengthening exercises, your stretching exercises, your changing your posture, your mechanics, the pain will return. And so I often tell patients, like, look, if you've had a history of needing repeated epidurals after epidurals, the question is, one, have you changed your habits? Have you done things differently? Sometimes it's just bad luck. Sometimes it's not the patient's fault. They've done everything that they possibly can, and that disc is just weak and it just reherniates again. But oftentimes when I start digging a little bit, I find that the patient it hasn't changed their habits enough. So I emphasize that, with epidural injections, we are trying to get permanent relief. A lot of surgeons don't think that that's possible, but I can tell you that I've seen it. I've had an epidural. I can tell you from personal experience it works. I haven't had one for 10 years since I herniated a disc. So, but you have to change, your habits going forward, and you have to know that once you've injured a disc, you're always more prone to re-injury in the future.
Well, Dr. Lee, I'd like to thank you so much for sharing your expertise with us and providing so much time so that we can have questions and answers. I did love your analogy of the Oreo cookie in the beginning. I think that really is a way for people to remember that. I know that I'll be able to remember that and when we talk about spines in the future. Lastly, before I thank our guests and our other panelists today, I'd like to remind everybody that we have another Macro Pro and Friends coming up on the 21st. It is going to be on the lessons learned from COVID. We have Dr. Deborah Dupree, Felicia Mente, and Rob Lowe, who's going to be panelists, and they're going to discuss all the things that we have learned from this last year in claims handling. Graciela, Veronica, Doctor, I'd like to thank you all for joining me today. Have a great day. Bye-bye, everyone.
Bye.
Bye-bye.